Both of our speakers tonight have very extensive knowledge and experience with blood-based testing, and they're both very great resources in this field. So with that, it is my privilege to introduce both of our guest speakers. We'll have Dr. Luke Yuhico kick us off. Dr. Yuhico completed his training at Cleveland Clinic, and he now practices at White Wilson Medical Center in Florida. He specializes in advanced bronchoscopy and pulmonary nodules. And then following Dr. Yuhico, we will hear from our oncologist, Dr. Riney, who completed his residency at the University of Tennessee, and he now practices at Methodist Cancer Center in Memphis. So while he is an oncologist, he actually heads the nodule program at the Cancer Center and specializes in lung cancer. So before I hand it over to Dr. Yuhico, I just want to mention we will be taking questions, but please do not submit those questions in the chat. There's a Q&A button at the bottom of the Zoom screen that you can submit questions to. That will go directly to our team. We will look at those questions and address them at the end of the call. So with that, Dr. Yuhico, I will let you take it away.
Good evening, everybody, and thank you for joining us. We've had previous discussions about blood-based testing, Nodify Lung and IQLung. We've talked about lung nodule programs, but today we talk about how to bring it all together. Because really, that's what it's all about. We have had so much technology. We've worked so hard to improve outcomes in lung cancer. But with all that we've come up with in the recent years, the biggest question is, how do we bring it into our practice? How do we make it reality for each of us in each part of the country that we're at? And so let's begin this by talking about the elephant in the room, lung cancer. The #1 cause of cancer death in men and women. We've heard it, we've said it, that if we added number 2, 3, and 4, breast, colon, and prostate, all three combined would still be less than lung cancer alone. But have we ever asked the question why? Why is that? Why is it that after everything we've done, lung cancer is still #1? Think about it. It's 2023. We've done a lot in the last years. We've flown to the moon. Okay, 25 years ago, we did not even have cell phones. And today we can pick up a cell phone and click a button and FaceTime someone in Antarctica, and it would be normal. We have self-driving cars. We've done so much in modern technology, so much that we could have never imagined 25 years ago. But still, we can't dethrone lung cancer. It's still #1. Is it for lack of trying? Well, no. We've done quite a bit in the last years. Many things. The National Lung Screening Trial came out, and we have now low-dose screening CAT scans. In the past, we thought, okay, we can't really catch lung cancer. We can't diagnose it because we can't find it. Well, that's not a reality anymore because we have low-dose screening CAT scans now. Now we have jobs called nodule navigators, lung nodule navigators, a job that never existed in the past, where now people are dedicated to solely following the life of a nodule. We now have software that is used to track nodules and organize all the data that we could not collate in the past. And we now have platforms, EBUS, navigational bronchoscopy, robotic bronchoscopy. 20 years ago, could we ever have imagined that we'd be using robots and holding an Xbox controller to diagnose lung cancer? All these things have developed in the last decade, and yet it's not enough. We've done so much, and yet lung cancer is still #1. Why is that? All this can be summarized in one word. The problem is prediction. We cannot predict the behavior of a nodule because lung nodules just don't follow the rules. Each one of us have seen it. We can have that upper lobe spiculated large nodule be cancer, but not be cancer. We can have that lower lobe round, non-spiculated nodule in a low-risk patient be a granuloma, but it can also be cancer. Truthfully, unlike many other disease conditions, the behavior of a lung nodule is so diverse that prediction is so difficult. So you take a disease entity with such a diverse behavior and you apply it to us, okay, healthcare providers who on our own selves are diverse. We've trained in different places. Okay, we've had different levels of experience. Some of us may see 100 nodules a month. Some of us may see one a month. Some of us may have had a strong family history of cancer in our own families. Some of us may have not. And therefore, we have our own biases. Add to that the country. Such a diverse landscape. You may be from California, where you have a lot of fungal disease, coccidioidomycosis. You may be from Ohio, where histoplasmosis is common. Or you may be from Florida, where it's an older population and a high smoking prevalence, where there's a lot of cancer. So a diverse disease process within a diverse landscape and within a group of providers that have diverse biases and training really makes it very difficult to predict. So what we really have always needed is something that can unify us, something that can go past the diversity that we have and unify us all. And truly what that is the patient. And so it is of truly great interest that now, in this day and age, we have testing for lung cancer that comes in the blood. Because what is blood? Okay, blood is something that is non-skewable. It is independent of our training. It is independent of our exposure. It's independent of the location we're at. It's independent of what this nodule looks like, what kind of CAT scan we have, what kind of resolution. It's a data point that is given to us by no one else but the patient. It's a data point we've never had before. And it's a data point where we can take something that is independent of any diversity we have and utilize that to unify our decision making. So in the past, we had nothing. Then we had imaging. And we've used these to the extent of our capability. And still, maybe it's not enough. Now we have blood. And the question is, what can blood do for us? So let's move forward and look at where we are today. Here are some data from the Panoptic study, and it looks at our capability to predict. It looked at our behavior at nodules from 8 to 30 millimeters. And basically, the summary of it was that of all nodules in tracking, 17% were malignant. And if nodules that were resected, 20% were benign. Think about that. That's 1 in 5. If there are 100 people in the room, 20 people, okay, will have resected benign nodules. 17 people will have cancer that's monitored. If you're in a family of 5, okay, to put that in perspective, if all 5 of you had nodules, 17%, 1 out of 5 would have cancer being monitored. Maybe that's acceptable, maybe that's forgivable, but we have to be better. Now, the comment on this was that it utilized nodules from 8 to 30 millimeters. And in real practice, do we really monitor a 25 millimeter nodule? Probably not. And so when the size is adjusted to a smaller size, meaning looking at nodules from 8 to 20 millimeters, something a bit more realistic, the results were as follows. Yes, 17% of patients in monitoring had cancer, but there was a higher prevalence of benign biopsies and benign resections. And so the bottom line of that is that the smaller the nodules are, the harder it is to predict. And we've done our best. I mean, we've done it all. We have imaging, we have all these platforms, we have nodule navigators, we have software, but yet still here we are. 17% of patients in monitoring have cancer, and there's a high prevalence of benign biopsies and benign resections. And so let's now move into these blood tests, okay? Nodify Lung and IQLung. I'm going to start with Nodify Lung on the left. And just to recap a little bit, as discussed in the past, Nodify Lung is a 2-part test. The first part is called CDT, which stands for Cancer Detection Test. It's a test that looks for malignant autoantibodies in the blood prevalent in lung cancer. It has 98% specificity and a 78% positive predictive value. High, such that if this test were positive, okay, you have a high risk patient. You have a patient that, independent of the nodule size, okay, you can consider high risk. If this test were to turn out positive, the test stops, you get the results, and you're moved into action. However, we recognize that this test is specific but not sensitive. And so if this test does not rule in lung cancer, we reflex into a second test called the XL2, which applies for two proteins. It is a rule-out test, the goal of which is to take your pre-test risk based on the Mayo Clinic calculator and reduce the risk in the hope of ruling out cancer. Results look as follows. Your first test, or the CDT, can show one of three results. Either A, no significant level of autoantibodies, meaning no autoantibodies were found, or B, a moderate or high level, meaning autoantibodies were found. If any autoantibodies are found, we are moved into action. With a 78% positive predictive value, it means that 3 out of 4 patients will have active lung cancer, and therefore, regardless of nodule size, that patient needs to have some sort of action. However, if you get a no significant level of autoantibodies, we recognize that this test is not sensitive, and therefore, we reflex into the second test, which is the XL2. Okay, this is what the result looks like when it's positive for the CDT. It's red, you get the results, you move forward. If negative, you get the XL2 and you get one of 3 results. The most important 2 categories that truly risk stratify are on the left and on the right. The first category is a likely benign category. In this category, your risk is reduced typically to less than 5% after application of the protein ratio. And therefore, regardless of how we may have viewed the nodule, regardless of size or speculation, it means that application of the ratio between inflammatory protein to lung cancer protein, the risk is reduced down to less than 5%. Based on the PanOptic study, at the end of 2 years, 98% of patients that had a likely benign result were true benign after 2 years. And so the hope is that if you have this result, you have fair confidence with 98% certainty that your nodule is benign. Not perfect, but 98%, I would say, is good enough in addition to our clinical decision-making. On the right side, you have the indeterminate category. I will say indeterminate does not mean no answer. Okay? Indeterminate means that this test, which was designed to rule out, this test, which was designed to bring down the risk of lung cancer, could not bring the risk down. It means that if your pre-test risk, for example, was 40%, it means that after application of the protein ratio, your risk is still 40%. Note, the CDT, which comes before, is specific but not sensitive. Okay? A positive CDT means action. A negative CDT means nothing. A lot of cancers will be missed, and most of them will fall into this category. I consider indeterminate as positive until proven otherwise, because we have a test with a very high sensitivity, and this test is telling you, I cannot rule out lung cancer. And therefore, if we have an indeterminate result, we have to consider the patient as a high-risk patient, and therefore consider the patient as positive until proven otherwise. The reduced risk category is a category where you have a percentage. It was this less than the pre-test risk of the Mayo Clinic calculator, but not less than 5%, as discussed in previous discussions. And in this category, we use still our clinical judgment. And so the typical result for a likely benign will look like this. You get a green. It says likely benign up there. And it lets you know that for this patient, the risk was reduced to less than 4%. And therefore, we can be confident that this patient is most likely benign with 98% certainty. Now, how do we bring this all together? If we were to take all the nodules that we see across the country, across the landscape of different physicians and healthcare providers and nurse practitioners and nurses, if we were to take the different locations we're at and the different appearances of nodules, ultimately, we all unify into 3 categories. We may have different size cutoffs. We may have different degrees of speculation. We may have different biases. But at the end of the day, all of us will bring patients into 3 general categories. This is what we do today. Category 1 is the radiographic tracking category. These are the patients that we take a look at and we feel are low risk. And we say, hey, I don't think you need a biopsy. I'm comfortable monitoring you. Let me do a scan in 3 months or in 6 months. Category B is, I call it the I'm not sure category. It's a patient that we're not so comfortable putting them in tracking, but at the same time, we're not so sure about biopsy. Maybe they're a high-risk patient. Maybe the nodule is not big, not small. Maybe we're sort of not sure where to go. And these are the patients that typically we say, you know what, maybe I'll get a PET scan. And the third category is the diagnostic category. We take a look, we say, hey, this is 20 millimeters, upper lobe, spiculated, active smoker. I know this is cancer. And they move to biopsy. All of us may have different size cutoffs, different biases. We may have different degrees of how aggressive or conservative we are based on how we practice, based on our location, based on the landscape, or based on our training. But ultimately, we're in these three categories. Now, this is where we are today. This is where we are with everything we've done with imaging, with PET scans, with training. Our goal is to elevate what we're doing. We're not looking to change what we're doing. We are looking to elevate it. We need to be better. And therefore, we need to take what we're doing and use what we have to be better. And to do that, we need to apply blood. 10 years ago, we didn't have blood. 10 years ago, we may have thought to ourselves, one day, will we ever have a blood test or two to help us make decisions? Well, here we are. It's available. It's been out for 5 years. Now is the time. And now we have it available to use. And the question is how we use it. So let me go over each category one by one and how I recommend using it for each category of patient. Category 1, the radiographic tracking category. Okay. In this category, we see a patient, we see a nodule, we think it's low risk. We move them to tracking 3 or 6 months. We know that based on Panoptic, 17% of patients in this category will be lung cancer. No one is 100% perfect. Whenever we put someone in tracking, there will be people who have cancer because every 3 centimeter nodule starts small. Every 5 centimeters nodule starts as 1 millimeter, and it grows. So what we would like is to have this blood test with every person we put in monitoring. There was a time we didn't have pictures. Now we do. With pictures, we did our best. We've monitored. We have caught cancer. And now we need to be better. Let's take blood. There was a time it was pictures only. Now it's pictures and blood. Let's take blood and use it with every person we put in tracking. And what we want, what we aim for, is to have the patient's blood test be congruent with our decision-making. Let the patient's biology tell us that, yes, I think you made the right choice. Therefore, when we send someone for tracking in 3 or 6 months, we order the Nodify Lung test. The Nodify Lung test may have several results. Ideally, we would like a result of likely benign. We know that the likely benign with 98% certainty will be benign in 2 years. Is it perfect? Absolutely not. Will it miss some cancers? Of course it will. No test is perfect. But if we have a test that has this degree of certainty, okay, and add it to our clinical judgment, then we will probably be more certain and more confident in our choices than we were before. And so when we make a decision to put someone in tracking for 3 or 6 months, based on our clinical judgment, based on how an image looks like, having a blood test that tells us that based on the patient's own biology, we probably made the right choice is something that gives us extra confidence that they truly belong on tracking. However, once in a while, you'll get a different result. You'll get an indeterminate XL2. You'll get a CDT that says autoantibodies are present. And these are the patients that we probably need to pull out. This test gives us confidence in those we monitor, and it's a safety net for those that we may have inadvertently misplaced in tracking. If we get a CDT that is showing autoantibodies or an indeterminate, we can have the patient called back and move them to a more aggressive category, whether it be biopsy or PET scan, but something that is not monitoring. Again, will we catch them all? We won't. Okay. But the goal is not to be perfect. The goal is just to be better than we are today. And so if 17% of people in monitoring are cancer, we can reduce that down to 8, then that is a win. And maybe 5 or 10 years from now, we'll have something more to reduce 8 to 4. But for now, if we can cut 17 to 8, if we can take some of these patients that we have misplaced in tracking and bring them out, then we've already done more today than we've done in the last 5 years. Next category is the I'm not sure category. It's the PET scan category. Now, PET scans are great tests, but they're interesting tests, as we know. They get glucose in their tracer, and PET scans light up. And if they light up and they're hot, they're wonderful. Okay. However, as we know, they are largely dependent on hypermetabolic activity. Okay. And therefore, the smaller the nodule, the less likelihood the PET scan will light up. Okay. So we have PET scans that light up with SUVs of 3 or 4, which I call PET lows or PET negatives. And so if we have a patient that we were already not comfortable with monitoring, a patient that we were already unsure about, and we get a PET scan, and the PET scan is low, meaning a 3 or a 4, I mean, what do we do with that result? Is it cancer? Is it not cancer? Could be a granuloma, could be Pseudomonas, could be Mycobacterium avium, could be inflammatory disease, but could also be cancer. If it's PET negative in a patient that we were uncomfortable monitoring, are we certain it's not carcinoid or adenocarcinoma in situ? We're not. Okay. We've had PET scans. We've had them for a long time. Okay. They've done their part to help us make decisions, but truly, they have not done enough because we are where we are at lung cancer. And so this blood test is something we can use with the PET scans to get better definition of decision making. I say, if there is a patient that we are uncomfortable with monitoring, if at the end of the day we are going to monitor this patient, let it be that I have 2 tests telling me that I'm at low probability of cancer. Because a falsely low or quote unquote false negative test is possible. Okay, I can have a false negative quote unquote PET scan. I can have a false negative quote unquote blood test. But what's the probability of 2 falsely low tests? I mean, it's possible, but it's not probable. And so if I have a patient that I was already not comfortable monitoring, and at the end of the day, if I choose to monitor the patient, let it be that I have a low risk PET and a low risk blood test. However, if any of the tests show high risk, then I move to a more aggressive category. The PET scan is a great test, but it's not perfect. The blood test is a great test, but not perfect. But let each other catch each other when they fall. And so the PET scan is hot, but the blood test is moderate risk. We move for aggressive management. If the PET scan is arbitrary, but the blood shows you an XL2 indeterminate or antibodies from the CDT, then move into aggressive management. However, if both tests show you that the likelihood of malignancy is low, then maybe we're a bit more comfortable with monitoring now because we have 2 tests and the likelihood of 2 false tests is less likely. The last category is the actionable category. These are the patients we take a look at and we know, okay, upper lobe, 20 millimeter, active smoker, most likely this is cancer. And we go for biopsy. Now, what do we do if the biopsy is not congruent with our clinical decision making? We were so sure this is going to be cancer, but then the biopsy is negative. So was our clinical impression wrong? Or was the biopsy inaccurate? I said, biopsies are not perfect. It's not that you're on the mark, but tumors are heterogeneous. Typically, we see a mass and we make the assumption that it's all cancer, but many times we have central tumor and peripheral inflammation, post-obstructive pneumonia, atelectasis. It's like a sunny side up egg phenomenon where there's the yolk, which is the cancer in the middle, and there's the egg white around it. However, in a tumor, the yolk may not always be central. And so your proceduralist may be on the mark making the biopsies, but the biopsies may be taking the white and not the yolk. And therefore, the biopsy was accurate, but not truly on the cancer. And so we have to make the decision whether to trust this biopsy or not, since it was not congruent with our clinical impression that we were so sure this is cancer. And so the Nodify Lung test can help us with this too. Because if the biopsy is negative and our Nodify Lung shows likely benign, then maybe we can be more comfortable with scanning in 3 months. However, if the biopsy is negative and the Nodify Lung test shows autoantibodies from CDT or an indeterminate XL2, maybe it warrants something a bit more aggressive, like a second biopsy for confirmation. The other utility of Nodify Lung is for proceduralists. We will have some patients that will go into a case with a pre-existing Nodify Lung. Say, for example, a Nodify Lung was done prior with a PET scan. If we go into a case and we have a Nodify Lung that's already CDT positive or already XL2 indeterminate, it may affect the case in that we take more time. So if we go, it may increase our pre-test probability of cancer. And therefore, if we initially go in and do our biopsies and get results like macrophages or white cells or atypical results, it may allow us to take a little bit more time or a little bit more risk because our pre-test risk is higher. And so this test not only helps in decision-making post-biopsy if negative, but it also helps a proceduralist make decisions during the case as to how much risk to take during the case. And lastly, of course, if the biopsy is positive, we order the IQLung, which we will discuss a bit later on. And so to summarize, okay, 3 categories that unite us. We're a diverse landscape of providers. We have a diverse landscape in the country, and nodules just don't follow the rules. However, all of us unite into 3 categories: radiographic tracking, the I'm not sure category, where we may order a PET scan, and the diagnostic category. This is where we are. This is where we have been. The goal is to take what we have and elevate ourselves. Take what we have now and apply it to each of these categories. It's actually a really exciting time. I mean, who would have thought that we'd have tests like these within our careers? But now we do. 5 years from now, there will be more. Maybe there will be artificial intelligence in 5 years. But we have to remember that today is the 5 years in the future of 5 years ago. 5 years ago, we looked for 5 years in the future, and here we are today. And now we have blood. We have tests that we never thought would have existed, and we are in a wave of change. We can be in front of that wave, on that wave, or behind it, and but it's happening with or without us. The goal is to take what we have today, apply it to all these categories, and use this in congruence with what we've done in the past, our imaging, to be better. Will we catch them all? Absolutely not. But that's not the goal. The goal is to be better. Never perfect, but better than yesterday. And so I wrap up Nodify Lung with that, and let me go into a case which we all have cases that sort of break our hearts. And this is a quick case I wanted to talk about. This is a patient, I named her Jane Doe, but I met her in 2021. She had a lower lobe nodule there on the left side. You see it's round, it's near the pleura, it's not spiculated, and was monitored by a primary care provider for about 3 years. Good job. Guidelines say 2 years, and they did 3 years. Stable, no change. And she was sent to me because of a new lung mass, 2 new lung masses, which you see. Here's the first one on the right, larger, spiculated, looks like cancer. The next one is down below, on the right as well, spiculated, larger. And so we met. I said, you have a stable nodule, but these 2 big masses here are new. She was still smoking. She had not wanted procedures in the past, but now it's time. And so we moved forward, planned for navigational bronchoscopy with EBUS, and I got the Nodify Lung test, and it showed presence of malignant antibodies. So no surprise, I thought it was cancer. Of course, it shows some antibodies. On the day of the bronchoscopy, we did a CAT scan for the case, and surprisingly, those 2 lung masses now were almost gone. If you look at the scans, they've now gotten smaller and almost resolved, and so we were in a bind. Here I was now with a positive CDT, and my 2 cancer masses were now almost gone. And I was still left with that stable, rounded, lower lobe nodule that had not changed in size for 3 years. So I said, okay, all I have is the nodule. Let's go down and biopsy the nodule. We did the biopsies. Surprisingly, it was adenocarcinoma. So I thought, okay, well, it's been stable for 3 years. Probably a low-grade adeno. That's why the CDT was positive. Did a PET scan, and the PET scan showed this result with an SUV of 4. EBUS was clean, looked pretty good, sent the patient to surgery. After surgery, the surgeon talked to me, and unfortunately, the patient had pleural metastases despite a negative EBUS and despite stability over 3 years. And so, despite therapy, 1 year later in 2022, this is her PET scan, and she has recurrence on the contralateral side. And I think about this case because I think to myself, they did everything right. They had a lower lobe nodule, round, not spiculated, and stable. They monitored it for 3 years, not 2, and it had not changed in size. The PET scan looked good. EBUS was negative. Who could have predicted pleural metastases? And I wonder, and I think, if 3 years ago, on the day this patient was first put into monitoring, if Nodify Lung was available, and at that point, this patient had a Nodify Lung that was positive, as it was when it was ordered, this patient would have gotten the biopsy 3 years ago. And I bet 3 years ago, there would have been no pleural metastases. She would have had clear margins, and she would have been cancer-free, versus now, where she has recurrence and her lifespan has changed. I am sure we've had many patients like this. Unfortunately, there are limitations within the PET scan. There are limitations of EBUS. There are limitations within everything we do. But this blood test would have changed the pathway for this patient if we had it 3 years ago, because this patient with a stable nodule would never have been in tracking. Today, we have the blood tests. We've never had them in the past. I hope that we can use them now to prevent patients from having the outcome of this patient of mine, who I think of all the time. Again, will we be perfect? No, but better. That is the goal. And so we move forward now. As I wrap up Nodify Lung and go to IQLung, I will be passing you on to a colleague of mine. However, before I pass you on, I wanted to go over IQLung from a pulmonologist's perspective. As you all know, it's a blood-based testing for driver mutations used in treatment of lung cancer. However, from a pulmonologist's perspective, there are utilities and there are important notes. In the past, we never really discussed liquid biopsy in the pulmonary world or the cardiothoracic world or the primary doctor world. However, there are important notes for this test which bring it to our attention today. And these are the following. So first is this, universal sampling. In the past, we have always gotten our driver mutations from tissue. However, we made the assumption that tumors were homogeneous, and we've realized today that we're wrong. Tumors are heterogeneous. They are like the map of a country. They have different parts, they have different biologies, and they may have different representations in different parts of the tumor. And therefore, when we biopsy one section and don't get EGFR, it does not mean there's no EGFR in the rest of it. Like this pizza slice. Just because there's no pepperoni in the bite doesn't mean there's no pepperoni in the rest of the pizza. By doing a blood test, we have universal sampling, where we can take the blood and get representation of the whole tumor. Second, tissue is always an issue. Pathologists will always say, I have had enough tissue for the diagnosis, but not enough for the markers. Easy to say, get more tissue. But if the nodule is on the pleura or the pericardium, I'm not sure about throwing 15 needles into the pericardium. The blood test gets us past that, because now we can get blood and adequate sampling without more risk to the patient trying to get more tissue. Third, upstream testing. Turnaround time now is quick. Turnaround time for tissue has typically been long, weeks. Treatment can be delayed while waiting for tissue results. Now with blood tests, we have turnaround times in less than a week. 3 days within the lab, call it 7 days, including travel time, with FedEx and obtaining results. Doing upstream testing from the procedural standpoint allows us to have results by the time of oncologist referral. And therefore, when we pass on our diagnosis and stage, we have our markers. And therefore, oncologists are actionable. And that is the key. Because let me end with this for my section. In history, the only goal we have ever had is condensing the time from identification to therapy. We have wanted to find them sooner and condense the time to definitive management. And the assumption was, if we can find them soon and get them quick to biopsy and quick to staging and quick to PET scan and quick to oncologist, once they hit oncologist, it's action. However, that's not the case because oncologists need all the data. So if we are to condense our identification to oncologist time down to 2 weeks or 1 week or whatever it is we do, but the oncologist has to wait for results from tissue for 3 to 4 weeks, well, did we really condense time at all? The goal is to make them actionable from the moment they receive a referral. And we can do that by moving our testing upstream. Okay. If we get our diagnosis and a stage and do our liquid biopsy testing with IQLung at point of diagnostics, such that when the oncologist gets the referral, they have everything together, then truly it's actionability on receipt of the referral. It's truly condensing time from identification to final therapy, and truly we've made a difference. And so from this point, I will pass you on to a dear colleague of mine, Dr. Riney, to tell us more about IQLung. Thank you.
Thank you, Dr. Yuhico. I appreciate that. And what a wonderful talk about Nodify, an introduction to IQLung there. As was mentioned earlier, I am program director for the nodule clinic here in Memphis, so have spent a lot of time working with Nodify as well, and really love the way they've combined a very specific and a very sensitive test out of one tube of blood to help me make those smart decisions like you were talking about and feel confident about them with my patients. But that's not what I am supposed to be talking about today. I'm talking about IQLung. And as y'all saw in the testing spectrum here, IQLung really comes for those individuals that have been diagnosed with a non-small cell lung cancer. So let's really get into this some with the time that I have available. So molecular testing in non-small cell lung cancer is really becoming more and more important. Whereas at one point it was really for your advanced stage and especially stage 4 patients. We're really talking about it more in earlier stages now with recent trials from the ADORA trials and from the Empower trials, where we're starting to use some of these immunotherapies and targeted therapies even in our early stage patients. And as you pointed out, Dr. Yuhico, there has been some frustration in the past with molecular testing, and especially with tissue-based molecular testing, because it's slow. It really is slow, usually several weeks with most companies that are out there today. And then even more discouraging is so many times, especially as we're becoming more advanced in our bronchoscopy techniques, we're getting nodules that are more and more peripheral. Sometimes there's not a lot of tissue available, and you have so many patients with insufficient tissue. And it's always frustrating when you've seen a patient, you've told them, all right, well, we're going to wait for some tissue results to see your molecular information so I can make smart decisions on what to start you on. And then a week, 2 weeks later, you get, oh, well, they had insufficient tissue. That can wind you up in this position. You don't want to be in this position asking someone to get a tissue biopsy again. That's not something your patient wants to hear and not something that you want to talk about. So that's really where there's a major problem in oncology is so many patients get started on first-line therapy without having biomarker results because there's pressure there. A patient's been diagnosed with cancer. They come to you, they say, Doc, I'm dying every day. You got to do something about it. You have so many issues with getting the information you need. So a lot of patients are started on first-line treatments without that results available. And this is from, information from like the MyLung Consortium, from the U.S. Oncology Network. This is a common problem across the country. And why does it matter to have those results? Well, because we know that patients that have driver mutations, they don't respond very well to standard of care therapy. The immune therapy that's really become a big backbone in lung and thoracic oncology doesn't work well in those settings. If patients have mutations that might be actionable in clinical trials and you've already started them on chemotherapy because you felt an urge to get them started, a lot of times they want them to be treatment naive and you might have missed that opportunity. Some patients don't respond to single agent immune therapy, even in the high PD-L1 setting where that's approved. And that's always been a difficult situation for myself and for oncologists is who treats, responds well to those. So this is a quick patient example that I'm just going to go through. And this is a 71-year-old lady that had this kind of 3 centimeter pulmonary mass, also had some hilar adenopathy, ended up getting biopsies and was found to have metastatic disease with bilateral lung involvement and had EGFR, ALK, PD-L1 sent off from tissue biopsy. PD-L1 was high, EGFR, ALK were negative. Seems like someone that would have responded to treatment, so was placed on immune therapy as a single agent, just pembrolizumab, and unfortunately wound up in the hospital, having shortness of breath, not really doing well just a few weeks after treatment was initiated, and had CT scans that were showing that there was increasing in size, that patient was really becoming hypoxic. And so kind of last ditch effort was to put the patient on platinum doublet chemotherapy. And did get some response out of that. Patient got out of the hospital, was doing better. And then further testing was done. Found out that patient had a MET exon 14 skipping mutation. So you really wonder with this patient, if they had further results, if maybe they had a complete molecular profile before starting therapy, would this patient's experience would have been different? Would they have known, well, we don't need to use the platinum doublet or the immune therapy. We can go straight on to a targeted therapy and expect a good response. So just an example of where having these results up front is really important, because you don't want to start first-line therapy with partial data. You want to really be able to get results fast and feel confident about what you're doing, as Drake here is helping us understand. And I love what Dr. Yuhico said, and I find it so helpful as a medical oncologist about this multidisciplinary and kind of integrated approach to molecular testing. When I have a pulmonologist that I'm working closely with that knows me well, and they're able to draw IQLung at the time of biopsy and get those results to me, it really not only increases our ability to detect actionable mutations, but it avoids delays in treatments. There's good collaboration there that helps speed along the patient's process. And really is able to help me address some of this evolving landscape of adjuvant therapy and how to treat patients. And I think that's really important because as Dr. Yuhico very wisely pointed out, a lot of times patients come to us with a biopsy. And that first visit is a story of one, well, hey, I need more information. I've got to send off these tests. It's really, I need to know more before I can confidently say what your first line treatment should look like. And that can sometimes result in serious delays. One of the things pulmonologists in town, when I was really starting out my practice, complained to me about is, hey, I send patients to some of the oncologists in town. I follow them up a month later, and they haven't even started treatment yet. How do we do better on that? And that's where IQLung has really helped us be able to do that. So IQLung involves a couple of different tests. There's a gene strat genomic test, which is a targeted test for your early stage patients. There's a gene strat NGS test, which is a more robust NGS panel for your advanced stage patients. And then there's VeriStrat, which is a proteomic test that helps identify patients' possible immune response to cancer, which is actually very interesting. We'll talk a little bit about today. And there to the right, key here is this is super fast. A lot of times from the time Biodesix receives the blood samples, about 72 hours, you'll start having results pop into your inbox or over your fax machine or however it is you prefer to see results. That's really amazing because that's far faster than tissue, and that's far faster even than other blood-based NGS companies. So what does the testing workflow look like? Well, in an ideal situation, you have blood drawn at time of biopsy when the patient's diagnosed. And there's one workflow pattern for your early stage patients, and that's stage 1 through 3A, and then a different workflow pattern for patients that are stage 3B and 4. And those are going to look like this. So early stage patients, as I mentioned, everyone is going to get some form of molecular testing. In an early stage, it's this gene strat genomic genomic test, which is a targeted 6-gene panel, which is going to look for mutations that can be common and possibly actionable in your early stage lung cancer patients. And you see here on the top of the screen, here's those mutations that are available. It's EGFR, ALK, ROS1, RET, BRAF, and KRAS. Because this is a more limited panel, a lot of times you're going to get results back a little bit quicker, but a highly sensitive test is for specific for these mutation detections. It's been clinically validated. And it is important to point out that if you don't feel that for your patient you need this entire panel, you can order a la carte, if you will. If you just want to know EGFR, I had a provider I was talking with once said, I just want to know their EGFR status and I want to know it quickly. Can you do that? Well, yes, you can. You can just check EGFR and get those results back super quick so you can make the right decisions for your patient. But kind of a targeted panel here for the adjuvant setting in your earlier stage lung cancer patients. And this is exactly what's included as part of that panel. It's important to point out here, it's not just your EGFR exon 19 mutations, it also includes exon 21, 20, the T790 resistance mutations, so some of the more uncommon EGFR mutations, KRAS G12C, which is actionable now, especially in advanced stages, but also G12D and G12V. So really kind of a robust panel. And if you want to pick and choose one or two of these mutations with that blood test, you are free to do that and can feel good about the results you get because it's very sensitive. You see clinical sensitivities there in the high 80, 90% range. Not all tumors shed a lot of DNA, but many of them do, especially in your more advanced stage patients. High specificity. If they detect it in blood, it's there. Hang your hat on it. You got that EGFR exon 19 mutation, order your osimertinib and get going. But I think the most important thing on this slide is on the right. That's a column to the far right is tissue concordance. And tissue concordance with some of these blood-based tests and modern laboratory techniques is really getting high. It's not perfect. You'll find some things in blood you don't find in tissue. As Dr. Yuhico mentioned, not all tumors are homogeneous. There is a heterogeneous part of tumors, and sometimes you pick those up in blood. Sometimes it's the other way around. But tissue concordance is far better than what it was even just 5 years ago with some of these blood-based testings, frequently in the 90 to high 90% at this point in time. And so then the other part of testing for your early stage lung cancer patients is going to be Veristrat. And this is an immune profiling test, which is very interesting. Veristrat in one form or another has been around for a while. But what it looks at is it's identifying chronic inflammatory disease states that are associated with more aggressive cancers. This is a binary test. You either get a Veristrat good or a Veristrat poor result, and that's it. It's just one or the other. But they have shown through the INSIGHT trial that patients that are Veristrat good have much better survivals than patients that are Veristrat poor, 2 to 3 times longer than Veristrat poor. And that's independent of their performance status, their mutations, PD-L1, what treatment you choose to put them on. So really a test that shows you patients that are more likely to have worse outcomes. And here's some data to show that. So if you have overall survival, and this is early and late stage, you see there on the left side, early stage, obviously the dotted line up top, and advanced stage being the solid line down below. You can stratify those patients according to Veristrat, which is this kind of host immune classifier that says, well, this patient is host immune hot, or this patient is host immune cold. And you can take those early stage and those advanced stage patients and really stratify them into 2 different categories of patients that are going to do well overall and patients that aren't going to do well overall. So why does that matter to me clinically? Well, it matters for a few reasons. One, I know the patients that I need to be more worried about, the patients I need to be more aggressive about, who really needs to get that adjuvant chemotherapy. We have a lot of reluctant patients in oncology. Or who needs to go on to close observation in that stage 1A that really needs to get those CT scans every 3 months instead of every 6 months. So who do you really keep a closer eye on in those settings? And this Veristrat result, it does hold true across not just early and advanced stage in general, but even breaking apart your early stage patients into local and regional. Veristrat's really able to bring out 2 separate patient populations that have clearly different overall survivals. The most interesting thing I find about this testing is in my stage 1B patients. Stage 1B is always a difficult situation for medical oncologists because if you look at NCCN guidelines, there's really not a lot of clarity given there. You'll see they say, well, you could observe or you could do chemotherapy for high-risk features, assuming margins are negative. And they talk about high-risk features being things like lymphovascular invasion or pleural invasion, wedge resection, inadequate lymph node dissection. Hopefully we're not seeing a lot of wedges at this point or just a few lymph nodes on dissection, because it's pretty clear what we're supposed to be doing when we're going in for lobectomy or segmentectomy even. But no one really knows what to do afterwards in stage 1B patients. And here on the top right, you see stage 1B patients do have higher rates of recurrence. Sometimes within 5 years, rates of recurrence are around 40%, and a lot of them are distant recurrences. So who do you give chemotherapy to and who do you not? And if you get a bunch of oncologists together, you might wind up with this argument of two gentlemen saying, well, stage 1B needs to have chemotherapy. And well, no, a lot of them are cured just from surgery alone. You don't have to expose everyone to that toxicity. But they do have a higher risk of recurrence. So where is the line here? There hasn't been a lot of proven benefit in an unselected population because these studies have been small. I consider Veristrat to be one of my high-risk features. If I have a stage 1B patient, they have high-risk features, or especially if they're Veristrat poor, hey, I have ample evidence that you might not do as well as someone. And it helps give me clarity personally in an area that's otherwise a gray space about what to do with those stage 1B patients, where honestly, no one knows what to do. There's just never been an adequately powered study to tell you what the accurate choice is there. So moving along, what about your advanced stage patients? Your advanced stage patients are still going to get GeneStrat, but at this point, it's going to become a 52 gene panel. So more of an NGS type of panel that can help you identify patients that not only have possible actionable changes, but as well as patients that might be suitable for clinical trials. It takes a little bit longer, 3 business days, because it's an expanded panel. Highly sensitive, again, specific mutation detection. And I think it's important to point out here that this is good for single nucleotide variants, your indels, copy number variants, fusion skipping. It does include DNA and RNA. So really is good across the gamut there. All those fun, geeky things that oncologists like to talk about when we go out and get drinks. So what is included in the panel? This is the actual 52 gene panel that is currently available. This is something that Biodesix is continuously reviewing and modifying as may need be. Everything in blue here is currently known as being actionable. It does include ERBB2, which very recently was added. And then you've got some other things that are common in clinical trials and being looked at, like your PIK3CA, IDH, P10, things like that. So really a robust panel to help you with your patient decisions. And again, very quick. So this brings us back for the last little bit of my portion to talk about Veristrat again, because you do get Veristrat in your early stage and your late stage, but how you use it really is going to change a little bit. And I think Veristrat in the advanced stage setting is very interesting to me in an area where Biodesix is really the only company doing something like this, and a lot of people struggle in this area. And it's all about immune therapy when you're talking about Veristrat in your advanced stage patients. So we're all probably aware of immune checkpoint inhibitors. On PD-L1 high patients, it's clear in NCCN guidelines and there's been evidence in the past that, hey, if you have these PD-L1 high patients, you can put them on an immune checkpoint inhibitor as a monotherapy and spare them the toxicity of chemotherapy in those cases, and they should do well. But the reality has been that if you've done this a lot, you've had patients that have really not done well with their immune checkpoint inhibitor as a single agent. You started them on therapy, saw them with CT scans 3 months later, and oh my gosh, he has progressive disease. And it's discouraging, it's frustrating. You wish you could go back. But at least to me, it was an area where I didn't ever understand why it happened, because the guy next to him looked exactly the same, PDL high 1 status, did great. Well, what they were able to show, again, an insight was that if you take these patient populations and you have the PD-L1 high patients extracted from them, using Veristrat, which again detects these chronic inflammatory states, you can pick out two different populations, and that's populations that do well on an immune checkpoint inhibitor as a monotherapy, and then populations that don't do well on an immune checkpoint inhibitor as a monotherapy. And that's according to their Veristrat good or Veristrat high status. And this has to do with that kind of host immune classifier status. So this has been me at times in the past. I get that PD-L1 high patient, and I'm sitting there, oh my gosh, well, what do? I don't want this person to do badly, but at the same time, I don't want to expose them to toxicity they don't need. What kind of choice do I make? And I'm sitting there sweating bullets trying to decide, well, what do I choose for grandma in this case? So Veristrat really helps you be able to pick out even beforehand. Those patients that are Veristrat good, they have a competent immune system. So patients that are PD-L1 high, you can put them on that immune checkpoint inhibitor. It's going to come activate the immune system, sort of unmask that cancer, if you will, and they're going to respond. They're going to have that apoptosis. But the Veristrat poor patients might not have the same experience through, cytokine release. The immune system has been deactivated or even excluded from that patient's tumor. So even though they have a high PD-L1 status and you're giving them an appropriate medication, the immune system isn't doing its part of the job. It's not there to induce apoptosis in those cells. So they're really not having a very good response. And on the right side of this graph here, the immune checkpoint inhibitor plus chemotherapy, I think, is important. That shows that in those PD-L1 high patients that are Veristrat poor, by giving them chemotherapy combined with the immune therapy, you're able to really turn around some of those results and get them to respond almost as well as if they had have been Veristrat good in the first place. And it seems like there's something about giving those chemotherapy rounds up front, which maybe resets that immune cold status and allows the immune system to then respond to immunotherapy after they finish their 4 cycles and go on to treatment afterwards. And this is just an example showing that. And I'm not trying to say that Veristrat measures anything about CD8 T cells and whether they're present in someone's cancer, because that has not straight been proven. But there is this idea that tumors that are immune hot versus immune cold, or Veristrat poor versus Veristrat good, have differing responses to immune checkpoint inhibitors. And this is a way that you can detect that before starting someone on treatment and feel confident about what you're doing. So how about another quick patient example? This is one of mine. Again, I think that Veristrat for some people is a little bit difficult to understand. I certainly get lots of questions about it. But I had this gentleman, a 70-year-old male, not a very good performance status. Performance status 2, maybe 1 if you're being really generous. Was diagnosed with a stage 4 squamous cell carcinoma, had metastatic disease in his adrenals as well as in his bones. And I sent off testing, and he ended up having PD-L1 that was 50-60%. Tumor mutational burden was high, EGFR and ALK were wild type. So typically, this is someone that I would have thought, all right, I should probably consider giving an immune checkpoint inhibitor as a single agent. This gentleman should do well with it. His performance status is maybe on the border for whether or not I want to give him chemotherapy. And I did send a GeneStrat NGS. All he had was some TP53 mutations, which might lead into why he wound up being Veristrat poor. We know TP53 mutations are associated with more aggressive malignancies, but he did come back as Veristrat poor status. So as soon as I saw that, early on in my visits with him, I saw, okay, this is not someone that I want to put on an immune checkpoint inhibitor as a single agent, because I know that in Veristrat poor status, his immune system is not active in his cancer, and he's likely to have a poor outcome. So I put him on chemotherapy and an immune therapy. Here's another little meme talking about how you got that PD-L1 high tumor cell. You want to do that immune checkpoint inhibitor. Veristrat steps in and says, I don't know if this is a good idea. So on this patient, the scan on the right, this is prior to treatment. He had a fairly large pulmonary mass, actually quite large pulmonary mass, as well as some effusion. He was actually relatively asymptomatic from a pulmonary standpoint, surprisingly. But I ended up doing chemotherapy and immune checkpoint inhibitor for him. And on the left side is his scan, and this is after he had his 4 cycles of chemotherapy and immune checkpoint inhibitor, and then had gotten an additional 6 cycles of Keytruda, and is really doing well. Has some cavitary spot there still from his original lesion, but really has had an exceptional response. That's someone, can you imagine if I had have chosen to just give him an immune checkpoint inhibitor because of his borderline performance status on PD-L1 high and high tumor mutational burden, he probably wouldn't have made it, a few months with that kind of treatment. So an area there where Veristrat really helped me make what I feel was clearly the correct choice for that patient. So again, this is just the testing strategy. Get that IQLung at the time of bronchoscopy or diagnosis if you can. I love it when I see a patient a week after their biopsy, I have their tissue diagnosis, I have their IQLung results, and that whole first visit has changed from one of, oh, well, yeah, you've got cancer, I need some more information, to one that's, hey, you've got cancer, this is what your molecular profiling shows, this is what the next few weeks are going to look like, this is what the next few months are going to look like. It's a better visit for me. Patients are have a better experience, and their satisfaction scores go up as well when you look at your Press Ganey. So everybody gets Veristrat. Early stage gets the targeted gene strat. Advanced stage gets the NGS panel. And with that, I will conclude my part.